Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, the State Trauma and Health Systems Training. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email addresses are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheets, and evaluations are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for physicians, nurses, and paramedics for today's program. In order to receive credits for this training, you must watch the entire program. Then physicians must complete and return the original sign-in sheet and evaluation, and nurses and paramedics must return only the sign-in sheet. I am Shauna Lane, the State Trauma and Stroke Program Administrator for the Office of EMS at the Alabama Department of Public Health. And with me is Dr. William Crawford, the State EMS Medical Director, and Dr. Sarah Nafsinger, the Assistant State EMS Medical Director, and Dr. Sid Brevard, the Associate Professor in the Department of Surgery at the University of South Alabama and the Chairman of the Alabama Committee on Trauma. We also have an update. We will have an update from our regional directors later in the program. And now to get us started, I would like to welcome Dr. Tom Miller, the State Health Officer. Welcome, Dr. Miller.
Thank you, Shauna. Good morning and welcome to our Alabama Statewide Trauma and Health Systems Training Program. In 2007, Alabama's legislature enacted a statewide trauma system bill to address the severe trauma health issues which are a major cause of death and long-term disability. 5 years later, in 2012, the legislature expanded the trauma system to include other acute health conditions. This led to statewide implementation for our stroke and upcoming STEMI systems of care. Trauma. According to the 2014 injury report from the Centers for Disease Control and Prevention, trauma injury accounts for 30% of all potential years of life lost in the United States, whereas cancer accounts for 16% and heart disease 12%. The impact on potential years of life lost is equal to deaths from cancer, heart disease, and HIV/AIDS combined. Trauma affects people of all ages, races, and income categories. In calendar year 2014, there were over 10,300 trauma cases reported in Alabama. For stroke, it's the fifth leading cause of death and kills about 130,000 Americans each year. On average, one American dies from stroke every 4 minutes. In Alabama, stroke is the leading cause of death. In 2014, the Alabama trauma system recorded nearly 3,800 stroke cases. And finally, STEMI, ST segment elevation myocardial infarction, also known by that acronym STEMI, is a type of heart attack which is the most severe. In the STEMI, a coronary artery is completely blocked off by a blood clot, which in turn causes all of the heart muscle that is blocked off by that clot to begin to die. Heart disease is the leading cause of death in the U.S., killing more than 600,000 people annually. 735,000 Americans have a heart attack each year. Of these, 525,000 are first occurrence heart attacks, and 210,000 happen to people who have already experienced a heart attack. In calendar year 2014, there were approximately 12,500 deaths from heart diseases in Alabama. 1 in 4 deaths in our state are due to heart disease. Alabama was actually ranked third in the nation for deaths due to heart disease. There were 571 STEMI cases reported in Alabama in calendar year 2014. So currently, for our statewide trauma and health system, 100% of our citizens are covered by this system. We're very fortunate to have leaders in the Birmingham region who have provided the groundwork needed to operate and expand our trauma and health system of care statewide. The trauma and health system is a collaborative effort. It involves pre-hospital personnel, hospital personnel, ADPH state office staff, and regional staff, some of whom you will have a chance to meet during this training. Alabama's trauma and health system is uniquely designed to include a centralized communication center which tracks the readiness of all designated trauma and health centers in real time. This feature enhances the routing process of traumatically injured, stroke, and STEMI patients to the most appropriate trauma and health center in the least amount of time. This is a life-saving system which will be demonstrated today when you hear the stories of individuals whose lives were changed by an acute event. I will now turn the program over to our State EMS Medical Director, Dr. Elwyn Crawford, who will provide you with more details about the day-to-day operations of the Alabama Trauma and Health Systems. Dr. Crawford.
Thank you. I'm going to give an update on the trauma system. In 2015, Alabama ranked 13th in the country for traumatic injury. Certainly not where we want to be, but better than we have been in the past, and we attribute that to the Alabama trauma system. Trauma injuries account for 41 million ED visits and a little over 2 million hospitalizations across the U.S. per year. And trauma injuries account for about 30% of all life years lost in the U.S. That leads cancer or heart disease, which accounts for 16% and 12% respectively. In Alabama, 900 people were killed in motor vehicle crashes in 2013. And also in 2013, motor vehicle crash deaths resulted in $44 billion in medical costs and work loss in the U.S. In Alabama alone, those same motor vehicle deaths resulted in $8 million in medical costs and a little over $1 billion in work loss, resulting in $1.2 billion total cost of crash-related deaths in 2013. So what are the qualities of a good trauma system? We're going to outline those here today. A trauma system, a good trauma system, is a network of hospitals with the commitment and the resources to care for the trauma system patients and an organized plan to route the most critical patients to the right hospital at the right time that's ready to care for them. That's the key, is to get those patients to the hospital with the capabilities at that time to care for those patients. It also has a constant monitoring of the system to correct problems, improve the system, and validate the quality of care that is being provided. The Alabama trauma system is really the only system in the United States that can do all of these. There are several other systems throughout the nation that can do parts of these, but really the only system in the country that can do all of these, and especially has real-time monitoring. Why do we need a trauma system? They save lives. As Dr. Miller alluded to, a voluntary trauma system was started in the 7-county BRIMS, or region around Birmingham, in 1996. And between 1996 and 2000, there were over 23,000 patients treated for major trauma. There was a 12% decrease in the death rate from trauma in the area that was being served by the trauma system at that time, with no change for the rest of the state. Obviously, this system was saving lives and reducing the death rate due to trauma in that area. The Alabama Trauma Plan is all a voluntary system. It's voluntary participation by the hospitals. The hospitals, both in-state and out-of-state hospitals, are inspected and designated for the level of services they request and can provide. We do not, at the health department, make that determination as far as what they think they can do. We let them tell us what the level of service that they think they can provide, and then we go in and survey them and make sure that they can provide those services. Our system is divided up into a level 1, level 2, and level 3 basic categorization. Again, out-of-state hospitals go through the same rigorous process that the in-state hospitals do. The thing that we are the most proud about is that no hospital has ever dropped out of the system once they were designated as a trauma system. So obviously the system works, and the hospitals have been happy with participating in this program. Trauma system patient routing is by a single high-tech communication center centered in Birmingham that coordinates patient transport to the appropriate facility initially, and then if that patient needs to be moved to an area or to a center of higher care, the communication center, also called the Alabama Trauma Communication Center, can facilitate that transfer to a higher level of care. This is done with a computer internet system that's staffed 24/7 with up-to-minute status of all the hospitals and all the resources. Again, this is something that is unique in the country, that we monitor this real time to make sure that the hospitals that are getting these trauma patients have the capability at that time to receive these patients. The hospitals are in control of their own destiny here. We do not change that status for them. They are able to tell us if they have this availability at that point in time of all the service lines that they have been designated to have, if they can actually receive those patients. Everything is monitored by a robust QA/QI process that is done at the regional level, also done at the state level. So again, good QA, good QI program means that we continually monitor the system and make improvements as needed. Trauma system, just total patients in calendar year 2015, there were a little over 13,000 total trauma patients. This is a breakdown of the different regions. Our state is divided up into 6 EMS regions. The BRIMS, or Birmingham region, had more patients than any, with a little over 4,000. Region 1 is in the Huntsville, North Alabama region, with 2,671 patients. East Alabama with 719 patients. West Alabama 754, with the Southeast basically the Dothan, Montgomery area, with a little over 2,400 patients, and then the Gulf region along the Gulf Coast with a little over 2,000 patients. Who needs a trauma system? A trauma patient is any patient that is injured. However, a trauma system patient has life-threatening injuries that require rapid, specialized care. Only 10 to 12% of trauma patients need to go to a trauma center and qualify for entry into our trauma system. Most injuries are minor and should be treated at a local community hospital. The method behind the madness. In the field, all injured patients go through 2 triage processes. The first is to determine if they should actually be entered into the trauma system. We have several ways to triage that. The second is what we call a secondary triage system. Once we determine, yes, the patient needs to go into the trauma system, where do they need to go? And we base that on a time limit or a time level of where they, level 1, level 2, level 3 hospitals, and how far that scene or that patient is from those hospitals. A patient can be entered for any of the 4 reasons: a physiologic problem, anatomic injury, mechanism injury, or EMS discretion. Physiologic criteria generally go to a level 1 if they're within an hour of transport time. Again, that's our secondary triage criteria. A systolic blood pressure less than 90 in an adult or less than 80 in a child 5 years or younger immediately goes into the trauma system as a physiologic unstable patient. Respiratory distress, respiratory rate less than 10 or greater than 29 in adults, or less than 20 and greater than 40 in a child 1 year of younger, again qualifies as a physiologically unstable patient and necessitates entry into the trauma system. Altered mental status is evidenced by a Glasgow Coma scale of 13 or less. 15 is normal, obviously, and 3 is totally unresponsive. A GCS of 9 or less goes to a level 1 if the transport time to a level 1 is less than 60 minutes. And the GCS of 10 to 13 goes to a level 2 or possibly to a level 3, depending on the availability of that level 3 and, again, the secondary triage criteria. Anatomic criteria: flail chest, 2 or more obvious proximal long bone fractures, such as a humerus and femur, would necessitate entry into the trauma system. Again, going to a level 1 if the transport time is less than 60 minutes. Penetrating injury of the head, neck, torso, groin associated with an energy transfer. In the same body area, a combination of trauma and burns, partial and full thickness burns of 15% or greater, would also be an anatomic criteria for entry into the trauma system. Amputation proximal to the wrist or ankle, 1 or more limbs which are paralyzed, unstable pelvic fractures is evidenced by a positive pelvic movement exam, A crushed, degloved, mangled, or pulseless extremity, both upper and lower extremity, would be an entry criterion to the trauma system. An open or depressed skull fracture. Again, all of these are anatomic conditions that would place a patient into the trauma system. Again, as far as a secondary triage criteria, if it's less than 60 minutes to a level 1, that patient will be transferred to a level 1 facility if that level 1 was available. If it's greater than 60 minutes, it would go to a level 2 or level 3. And if it's less than 60 minutes but the level 1 is not available, then it would go to a level 2 or level 3. Also, the third way to put a patient into the trauma system is what we call a mechanism of injury criteria. A patient with the same method of restraint in the same seating area as a dead victim. Ejection of the patient from an enclosed vehicle, a motorcycle or bicycle, ATV crash with the patient being thrown at least 10 feet from the motorcycle or bicycle. Again, these would go to a level 2 or level 3 and potentially go to a level 1 if the level 1 is closer. Also, an auto versus pedestrian with a significant impact with the patient thrown or run over by a vehicle would be a mechanism of injury criteria. An unbroken fall of 20 feet or more onto a hard surface would be an entry criteria for mechanism of entry into the trauma system. The fourth way to place a patient into the system is what we call EMS or EMS personnel discretion criteria. They usually go to a level 2 or level 3, but again, they can go to a level 1 depending on the secondary triage criteria. If the EMT or paramedic is convinced the patient could have a severe injury that is not yet obvious, the patient should be entered into the trauma system. If there's an EMSP suspicion of severity of the trauma or injury may be raised by the following factors: age greater than 55, age less than 5, environmental conditions, hot or cold injuries, patient's previous medical history such as insulin-dependent diabetes, cardiac condition, immunodeficiency disorder, bleeding disorder, on Coumadin or any other anticoagulants, COPD, emphysema, pregnancy, and an extrication time greater than 20 minutes with heavy extrication tools utilized. All should raise a suspicion that this patient may have occult injuries that are not that are not yet obvious, and this should be entered into the system under an EMS discretion. Again, these will go to a level 2 or level 3, possibly to a level 1 center depending on secondary triage criteria. Also, EMS discretion, a history of more than momentary loss of consciousness. Process to enter the patient from the field. An EMT or paramedic evaluates the patient and determines that they meet the criteria to be entered into the system either by physiologic criteria, anatomic criteria, mechanism of an injury, or EMS discretion. That EMS personnel calls the Alabama Trauma Communication Center and gives a patient report, and then in conjunction with the ATCC operator, that EMSP will agree on a level of care the patient needs. ATCC will give their recommendations, and then that patient is routed to the most appropriate hospital based on the availability and based on secondary triage criteria at that point in time. ATCC fills out a patient report and sends the hospital that is receiving that patient, usually prints out in the emergency department, a patient report giving them an update that the patient is inbound to them with the following injuries, such as the EMSP has already communicated to the ATCC. The ATCC also calls the emergency department and lets them have a voice report as well. Within 48 hours of this happening, the emergency department staff should fill out a patient care feedback section of the patient report and fax this back to ATCC so that we can get that information back out to the EMSP and to the services as a QA/QI, and also just close the loop as far as getting that information back as an educational piece so that they actually know what happened to those patients that they have cared for. This is just a sample of the trauma patient report. That's again, this fax to the receiving hospital from ATCC, and then that same report is faxed back with the bottom filled out as far as the injuries, just a synopsis of what they found out on their initial assessment. Special cases, no airway. Those patients will go to the closest ED along with hemodynamically unstable patient with no IV and unable to stop severe hemorrhage. Those patients will go to the closest emergency department, regardless if that emergency department or that hospital is included in the Alabama trauma system. We will call those hospitals and let them know that they will be having those patients arrive, again, with no airway, hemodynamically unstable with no IV, and unable to stop severe hemorrhage. We will, at TCC, at that point in time, help that hospital once they establish an airway, establish an IV, control the hemorrhage. We will actually help those hospitals get that patient out of that hospital to the most appropriate facility that can handle those cases. But again, we will always err on the patient safety and patient care side, and those patients with those conditions will be routed to the closest hospital, regardless of if that hospital is a trauma center or not. Also, special cases, ages 15 years or younger. We will send those patients to a pediatric level 1 if they've been included in the system. If that pediatric level 1 center is less than 60 minutes transport time. If they do not have a pediatric level 1 less than 60 minutes, then that patient may go to the closest level 1 or level 2 adult center, and then they will be stabilized there and then transferred if the need be. Also, closest level 3 trauma center can care for this pediatric patient if the closest level 1 or level 2 adult facility is greater than 60 minutes. So the gist of this is we try to get them to a pediatric level 1 center if they're less than 60 minutes. If we do not have a closest pediatric center that's less than 60 minutes, we will route those patients to the closest level 1 or level 2 adult center to stabilize. If it's less than 60 minutes, to the closest level 1 or level 2 adult. If it's greater than 60 minutes, then we may route to a level 3 adult center. Again, TCC is very good about helping that facility get that patient moved to a pediatric center once that patient has been stabilized. Pregnancy is also a special case. Level 1 center should receive that patient if it's less than 60 minutes of total transport time. If it's greater than 60 minutes to a level 1, the level 2 or level 3 will receive that patient. Again, TCC will help move that patient if the need arises. Right. What about patients who do not come by ambulance and or come to the hospital and were what we call under triage, or were not put in the system by the EMS personnel? These patients can be entered into the system by the hospital staff. Even if the hospital is not planning to transfer them, they can still be entered into the system. For patients that need to be transferred, if they have a physiologic criteria and they're physiologically unstable, TCC can help arrange that transfer from that facility to a higher level of care without an actual physician-to-physician discussion. TCC can actually accept that transfer and move them to a higher level of care. If the patient has stable vital signs such as anatomic injury or burns, the ATCC will connect the physician at the receiving hospital and the physician at the sending hospital, and we will get them together and they will discuss the case. Again, a patient is unstable physiologically. We try to cut the time that that patient will receive definitive care so TCC can facilitate that transfer without waiting on a physician at the receiving facility. Anatomic criteria for a hospital to enter a patient into the trauma system: flail chest, the very same anatomic criteria that we have for the EMS personnel in the field. Flail chest, 2 or more obvious proximal long bone fractures such as humerus or femur, penetrating injury of the head, neck, torso, or groin with an energy transfer. Again, patient has in the same body area a combination of trauma and burns. Patient has an amputation proximal to the wrist or ankle and a paralyzed limb, 1 or more paralyzed limbs. Patient has a pelvic fracture, again, that's demonstrated by X-ray or other imaging techniques such as CT. Significant internal injuries that are not found during the hospital evaluation in the referring hospital does not have the surgical resources to manage them. That patient can be entered and TCC can arrange transfer to a higher level of care. Again, the patient, if they have a crushed glove mangled at a pulseless extremity, either upper or lower, the hospital has the capability to enter them as an anatomic condition into the trauma system. A patient with an open or depressed skull fracture also meets anatomic entry criteria by the hospital. Physiologic criteria for the hospital, again, the same criteria that the EMS personnel in the field abides by. Blood pressure less than 90 in an adult, child 6 or older less than 80, a respiratory distress such as a respiratory rate less than 10 or greater than 29 in adults, or less than 20 or greater than 60 in a newborn, less than 20 or greater than 40 in a child 3 years or younger. And then less than 12 or greater than 29 in a child 4 years or older. Head trauma with Glasgow Coma Scale of 13 or less, or head trauma with any neurologic changes in a child 5 years or younger, hospital can enter these patients as a physiologic unstable patient. The level of trauma center to which this patient will be transferred would depend on the regional secondary triage criteria. Again, generally only GCS of 9 or less are triaged to a level 1 unless a CT scan reveals an intracranial bleeding with a GCS of 10, 11, 12, then that patient still may go to a level 1. Burn criteria for a hospital to enter a patient into the trauma system: partial thickness burns of greater than 10% of the total body surface area, or burns involving the face, hands, feet, genitalia, perineum, or major joints. Third-degree burns in any age group, electrical burns, including lightning injuries, chemical or inhalation injury, burn injuries in patients with pre-existing medical disorders that could complicate management, prolonged recovery, etc., would necessitate for entry into the trauma system as a burn patient. Also, any patient with burns and concomitant trauma, such as fractures in which the burn injury poses the greatest risk of mortality or morbidity. In these cases, the trauma condition may be stabilized initially in a trauma center before transfer to a burn center. Burn children in the hospitals without qualified personnel or equipment for the care of children necessitates entry from the hospital for a burn center. Any burn injury in the patients who will require special social, emotional, or rehabilitative intervention. As a general rule, mechanisms of injury and hospital discretion are not reasons to enter a patient into the trauma system. So recapping, EMS personnel in the field can enter patients to the trauma system either by physiologic or anatomic conditions. EMS discretion mechanism injury. Hospitals can only enter the person generally as physiologic or anatomic entry criteria, and not hospital discretion or mechanism of injury. Trauma system patient routing. Each participating hospital, as I've mentioned before, will be connected to the Alabama Trauma Communication Center so that there's a constant monitoring of the status of all the hospitals. When the patient needs to be moved to a higher level of care, the TCC will route the patient to the correct ready hospital, either from the field or interfacility transfer, depending on the patient's injuries. Transportation, both air and ground, can be arranged by the TCC if needed, and the transfer of patients from local hospitals to the correct trauma center can also be coordinated by the TCC as an interfacility transfer. These are just photos of our LifeTrack workstation, and as you can see, that this is an example of Region 1 in North Alabama. May be very difficult to see, but that is something that the TCC operator in Birmingham is looking at, and that those green rectangles means that they have the availability to take care of those conditions, and they may have a trauma surgeon available, CT scanner available, ER available. Those red rectangles means that service line or that capability, such as CT, operating room, etc., are not available at this real time. So that is how we determine, after looking at this LifeTrack workstation, if that hospital that patient needs to go to is available at that point to be able to take care of those patients. Same thing with East, BRIMS. As you can see, BRIMS has much more on their tracker than the rest of them because they are actually monitoring a STEMI and a stroke system as well, and they have more hospital or a lot of hospitals in that area. West, same thing. Region 5 Southeast, as you can tell, Region 5 also has lots of hospitals and lots of green, lots of red on there because they're taking care of a stroke as well. The Gulf region also has quite a few hospitals, and again, green and red. All right. This is a picture of the LifeTrack workstation in the emergency department. The emergency department at that receiving hospital can update their status by going in and clicking a few icons on that workstation, and they can change their status from green to red. Nobody else can do that. Only that hospital can do that. Participating hospitals, it's all completely voluntarily. Administration and surgical staff must agree to participate. We engage all of these people when we talk with the hospitals about coming into the trauma system. The participating hospitals will be surveyed, as I mentioned before, both in-state and out-of-state hospitals, to make sure that they can provide the level of care that they say they can and that they would like to provide. Again, each hospital decides when they become red or green. If they do not have a service line, such as neurosurgery available and they're a level 1 at that point in time, they can turn themselves red for neurosurgery, and they will not receive a neurosurgical patient. Level 1 for ortho, or maybe even the OR is unavailable. So only the hospital can determine if they're going to be red or green. We monitor that, the hospital's red or green status, especially the red status. TCC or the state staff cannot override this. A patient still has the right to determine which hospital they want to go to. So regardless of if a hospital is red, green, how far away they are from the patient, etc., it doesn't come into play if the patient decides they want to go to a certain hospital. Patient's choice always overrides all other components of the system. The hospital has a responsibility to keep up-to-date status as far as their green or red status, so that they will not receive patients if they don't have the availability or they're red at that point in time to take care of these patients. Why our system is unique: it correctly identifies the patients who need trauma care by our entry criteria. It anticipates the resources needed to treat these patients, and it locates the available needed resources, and it routes these patients to the right hospital the first time, and hopefully that reduces the amount of time that we have to transfer these patients to a higher level of care, and obviously this reduces time to definitive diagnosis and improves patient care and reduces mortality and morbidity. Our system arranges interfacility transfers as needed. It improves the care by a robust QA/QI process that we do every day, both at the TCC level with our regional staff and our state staff. We meet to determine if we need to improve our QA/QI, and we talk about cases. We're constantly trying to monitor the system so that our system is in a constant state of evaluation so that we can improve the system as needed. This also keeps the hospital and doctors in control of the process. The hospitals and the doctors at those hospitals are the only ones that can determine if that hospital is green or red at that point in time. This is just a map of our state. We have 6 trauma regions that coincide with our 6 regional EMS regions. And the goal is to have a level 1 in each region. We do not have that yet. That's our goal. We continually work toward that goal. But we also have some out-of-state hospitals that fill in the gap for us. We have Erlanger in Tennessee. We have Tupelo, also Baptist Pensacola, and Sacred Heart that all receive patients from our routing mechanism, and they are monitored just like our in-state hospitals. All right, thank you very much.
Thank you, Dr. Crawford, for the very detailed overview of our trauma system. At this point, we're going to turn our attention to receive a national trauma care update from Dr. Sid Brevard. Dr. Brevard?
Thank you, Ms. Lang, for the opportunity to talk about trauma today. As was mentioned, trauma is the #1 cause of death worldwide for persons under the age of 44. So that comes out to about 400 deaths a day in the United States. Over 50 children die every day. And so it is a significant problem for us in the United States. And then economically, you mentioned the effects. So 11 million transient disabilities per year, with 500,000 being permanent, which you have to give kudos to our rehab colleagues if we go from 11 million to 500,000. So if you look at it compared to other diseases, you'd say it's not a major problem. We're number 4. But if you look at it for years of productive life lost, then trauma continues to be an issue and something that needs our attention. What are our major forms of trauma? Motor vehicle continues to be a significant problem. And when I say motor vehicle, I mean motorcycles, ATVs, everything. Falls are a growing problem, and firearms continue to be a problem. And I'll talk about each of these a little bit. The blue is Alabama, the green is nationwide. So you see that here in Alabama, we are lagging behind the nation in our ability to prevent death in motor vehicle collisions. So the first thing you'd think is that safety belts. Well, actually, no, we do better than the nation. So I think it goes back to that goal of having a level 1 trauma center in each region. We don't have that yet. And so we do have area to improve, and that's what the system's all about. Now, as far as falls go, motor vehicle collisions used to be the #1 reason for death. Falls are now at the same level, or in some places higher than the admissions for motor vehicle collisions. And if you look at this slide, it shows that we're actually not getting better at taking care of these patients. Their mortality is actually going up. And that goes to the fact that there are more and more older patients in the United States, and they're all on some type of antiplatelet drug or a NOAC or some kind of other medication. So not only are we getting more falls, the patients are more and more complicated. And then in firearms, you don't have to, all you have to do is turn on the news to realize that firearms are still a problem. And here in the state of Alabama, it continues to be a problem also. I know at my facility, we're actually at the 20% of our admissions are for penetrating injury. So our consolidated system really helps, as was pointed out, look at our status board every day to see what the other facilities in our region are doing. And then from the national level, this is a campaign that you may or may not have heard of. It's called Stop the Bleed, and it's being supported by the Department of Homeland Security and the White House and being propagated by national organizations. And the goal is to train everybody in the United States on how to stop bleeding. And that starts with direct pressure, and if that doesn't work, then tourniquet application. And the goal, if you look at the slide there, the picture, everywhere in the U.S. where there's an AED, they envision a Stop the Bleed bag. And in that bag are tourniquets, gloves, and dressings. So that's coming down from the national level. So in summary, the Alabama trauma is still an issue, and that's why we're all here today. We love the centralized command and control. We definitely have something that other places don't. But we do not have state funding for hospital care of the trauma system. Every state that is contiguous with us has some type of system, so we still have room to grow.
Thank you, Dr. Brevard. At this point, we're going to receive additional information regarding our trauma system and linking the importance of our communication center from Joe Acker. Joe?
I need the slide clicker, if you would. Thank you. Shauna, and thanks for the great information from everybody. We'll try to operationalize this a little bit and take where we are with a couple of things. We're going to start out with a great success story, and we're going to end with a great success story. And you kind of have to listen to me in the middle. So, you know, there is good stuff at the start, and hopefully really, really good stuff at the end. This is we're going to look at a video in just a second. I want to frame it for you. This is a trauma that happened this spring. Both of these traumas are recent. They're from this spring. This was 20-year-old male, motor vehicle crash, rollover. Wasn't a male. 20-year-old female with a motor vehicle crash, rollover with ejection. She was found in the middle of the road. Her airways clear, respiratory rates 18, SpO2 100% on a 15-liter non-rebreather. You can see there what her pressure is, and it's not bad. Her pulse rate's not bad either. However, her Glasgow Coma Scale score was 10. They went on ahead and they created a patent airway, and they RSI'd her. So she was now, as she came into the trauma system with pre-hospital movement of that patient via aircraft. So the hospital outcome report, and you're going to get a chance to see this patient in just a second on a video. She had a left subdural hematoma or hemorrhage. She had a right subdural hemorrhage, free air in the skull, left iliac fracture, T5 and 6 fractures, lung bruising, and facial fractures. Okay, we're ready for the video.
In this edition of Living Well, you'll meet neurospine patient and trauma survivor Eliza Kempton, who survived multiple injuries sustained in a car crash.
I'd been on my apartment all day doing homework and left late at night. I can't tell you anything about the accident because the last thing I remember was packing my car. The accident happened an hour into the drive and I lost the whole hour. I can't remember anything. I broke the left driver's side window with the left side of my head, and I fractured the entire side of my skull. And then flew out of the car 70 feet, landed on the back of my head, had contusions, lots of bleeding, lots of fractures. Every day, you just gotta wake up with a positive mindset. All you gotta do is focus on what can I do to improve today. It's okay to be honest with what you're going through, because it's not easy. And statistically, with my kind of accident, I'm not supposed to survive. You don't need to worry about next week or next month or a year from now. You need to focus on today. What can you be doing today to make yourself better? And that's what you need to focus on every day, one day at a time. 2 months since my accident, it went by so fast. I feel like it was yesterday. And I'm up walking around just like my normal self. I mean, of course, there's a few things, but I'm walking around the house on my own, getting breakfast on my own, getting showered by my own, getting dressed on my own, everything. So if I can do it, anyone can do it. My goal is 3 months, back to work, back to living on my own. My whole life I've always known that whatever it is, I'm going to help people. So that's what I want to spend my life doing. And especially after this, I think everything's going to change, obviously. Maybe I can help someone going through a similar situation.
Okay, that was really a great chance to look at a trauma survivor. We'll have a chance later on, after we go through some triage criteria, to look at another survivor that shouldn't be a survivor but clearly is. So we want to look at triage criteria and see how well those things that Dr. Miller, Dr. Crawford, Dr. Brevard talked to you about, how good a predictor are they when we use this in the field to make a determination about entering the patient in the trauma system, and how good a predictor are they as to whether that patient will be admitted to a hospital or not. I have no disclosures to make. Why do we do triage? We want the right patient to the right hospital. We know what our current capability, our current capacities are. That's what we use. It's the standard of care, and it's the standard of practice for us in Alabama because it's blessed by the State Committee of Public Health. And it gives us some flexibility, especially with EMTALA issues, if we follow triage and we follow inter-facility transfers the right way. It's the real key to a trauma system to make sure that the trauma patient gets to the right hospital the first time, or if they've got to be transferred, they get transferred to the right hospital in that secondary transfer. And we use it for secondary triage. We've talked about that with what Dr. Crawford's talked about. So how do we define over-triage and under-triage? Over-triage is the patient was entered in the trauma system, and then that patient was discharged from the ED once they were evaluated by emergency medicine, usually, or the traumatologist in a level 1 center. Under-triage is that the patient should have been put in the trauma system, was not put in the trauma system, and had significant injuries upon evaluation with the hospital. Now, not all under triage are we responsible for in EMS because we don't yet have X-ray, we don't yet have CTs, but we have what I would call EMS gestalt. We look at patients, we look and know what these patients that we've seen over the past years have shown us, especially with a feedback mechanism. So this data looks at all trauma patients entered in the last 3 years, 2013 through 15, that were entered by you in pre-hospital care or hospital entries. They both are in this data. And so we got 72% of all of the hospital outcome reports that Dr. Crawford talked about back during this time period, which is an improvement. We'd still like to be 90, 95%, and we'll keep trying to get better. But we had an overall admit rate in the system of 59.5%, or a 40.5% over triage. Now, the national folks, both CDC and College of Surgeons, tell us that, you know, as long as we're 40% on over triage, we're doing good. If we get if we get higher on over triage, then we begin to miss patients. So there's kind of a sweet spot in there. And what we want to look at is how close are we to that sweet spot in the current system. I can tell you this is a dramatic improvement from where we were when we pulled this data in the beginning within BRIMS, when we pulled it over the years. So there's some really, really interesting stuff here. This PowerPoint gives you an idea of why patients come in the system. If you added up all those numbers, you'd say, whoa, wait a minute, Joe, there's more patients than we have in the system. Well, that's because if a patient comes in with meets physiologic criteria, is a penetrating injury, and also had a fractured bone, then, or 2 or more proximal long bone fractures, they would be listed in 3 criteria there. Now, this gives you an idea of how good a predictor for the trauma system it is. And I know this is a busy slide. This will be busy for Physiologic, for MOI, and for Anatomic. But what I'd like for you to look at is just the summary at the bottom. It gives you an exact determination in that slide for each of those as how good a predictor each of these criteria are. Now, recognize, our system's different in another way, because when you look at national statistics or CDC statistics, they pull their statistics from the trauma registry. We don't pull ours from the trauma registry. We pull our data from exactly what you is when you call in and enter a trauma patient, whether it's pre-hospital or in-hospital, what you tell us about the patient. We don't go back after the fact and try to go through the hospital records and so forth like trauma registries have to do, and that's where the data for the rest of the U.S. is pulled from, in that, not what we do in pre-hospital or in-hospital. So you can get some really, really good idea. You can see that what we consider a critically unstable patient almost is 100% certainty that they're going to be admitted. And these are patients that have a combination of physiologic, their criteria with their pressure less than 90, their respiratory distress, and significantly altered level of mentation with a GCSS of 9 or less. So that's a great predictor, but the others are very good predictors also. If you notice, we're all above 60% in all our physiologic criteria. Now, anatomic, you know, we've got some variability here. And again, you can see on the bottom there that some of the predictors are not quite as good as the others. But on these, almost all of these are above our criteria of 60%. And so we're doing a good job. What you're doing in the field and using these predictors, and hopefully it'll be even better after you look at this material and say, wow, in that presentation, I recognize we made the right call putting the patient in the trauma system. And there are some things that sometimes we look at and we say, well, I think the patient's okay. Maybe they're going to do all right. Maybe we don't need to put them in. But by golly, you look at those anatomic predictors and you see exactly how good a predictor they are to say that this patient's going to be admitted to the hospital. Mechanism of injury, you can see that they're not quite as good a predictor as anatomic criteria, and when we're doing our field triage, we want to look physiologically first. If they meet the criteria, then by golly, they're in the system. If they don't meet physiologic, then we look at anatomic. If they don't meet anatomic, then we look at MOI. And so our MOI have already called out, for lack of a better way to put it, exactly what the physiologic and the anatomic do for us. So these are not quite as good. Dr. Brevard talked about falls. We're making some changes in the way that we do our data on falls, and we'll be asking a little bit for some different terminology in a little bit, and we will also be able to predict a little bit better how good our falls are, because right now that falls category is 20 feet or greater, and sometimes it's less than 20. Sometimes it's, whatever somebody puts in and the way that you want to call that fall. I'll talk in just a minute how we want to clean this up a little bit and make that an even greater predictor. And Dr. Brevard's exactly right. In some trauma systems, 70 to 80% of their patients are coming in under the fall criteria. And that is just a tremendous input into the trauma system. Now we look at EMS personnel discretion. And these are patients who didn't meet physiologic, anatomic, or mechanism of injury patients. And so almost 51 to 52% of our patients come in under EMS discretion. There are a lot of systems that don't use EMS discretion. Well, these are patients. 47% of these patients were admitted to the hospital. That means without discretion, there would be 47% of the overall Alabama trauma system patients that would have not gotten the care and the potential for life-saving had they not been entered into the system. And so what I would like to get across to all of us in EMS is that we do a great job of looking at those patients. We do a great job with Gestalt. We do a great job of erring on the side of what the trauma patient may have. They may not present in one of those other criteria, but by golly, they're sick. Over 47% or over 53% of these patients are really, really sick. And so this is something that we continue to look at. There were issues raised in the past about our over-triage rates. This has really, really improved over the years. We think the feedback forms really make a difference in that. And so then we wanted to look at a few of the comorbid factors. This really, really surprised me when we pulled the data this time. Age of 5 or less, it does a pretty good job. But look at that geriatric trauma, 55 years of age and over. Look at what adding that comorbid factor does to our admit rate on trauma. And that, again, goes back to what Dr. Brevard talked about, all of us have talked about. We are an aging population, some of us more aged than others, and we recognize that trauma etiology, cause of trauma, how the body reacts to trauma in geriatric patients is really, really significant. While we have a lot of years life lost with pediatric patients that are not well cared for, we have a tremendous amount of resources that go to take care of geriatric patients. And what we can do in EMS is recognize these geriatric patients. It takes less to hurt the patient. It takes more to heal the patient. And it takes a better trauma system to improve the outcome of these geriatric patients. So, with having said this, a couple of things to talk about. We want to change to ground level falls rather than a fall from a standing position. Fall from a standing position sounds like the patient was standing there and went, bam, fell out on the floor. Or had, as we used to call it, East Tennessee dropsy. They just dropped out. Well, Ground level falls are that the patient was walking, something happened, they fell. We don't know whether that's a medical cause. We don't know whether that's a trauma cause. But it wasn't just he fell out type deal. We need to talk about eventually moving toward heart rate parameters for trauma patients. At ATCC, when we get a patient, we'll ask for the heart rate on the patient. We may ask for your heart rate too if it's a good case. But the real issue is we want to know that. That's the best predictor we've got that that patient is either in shock or is moving toward shock. And that is something we need to identify early and make sure those patients get routed. We need to know if these patients are on platelet inhibitors. Again, the two physicians have talked about that. But we also need to know if they're on cardiac meds because we got beta blockers. They aren't going to give us what we need to know about the heart rate. And other antiarrhythmias change the way that these patients may be cared for within the trauma hospital, whether they're a level 1 or level 2. We're constantly looking at triage factor modifications and changes. We'll do some as Dr. Knopfsinger's group reworks the protocols in the near future, and we increase some things through the protocol subcommittee process and SMIC with the depressed skull fractures and so forth, and we'll modify that. We want feedback to you as an EMS provider, EMS personnel. If you're not getting your feedback from your region on the hospital outcome data, then your region needs to know about that. It's the only way we learn. If you're a hospital and you're not giving us that feedback, we've got to have that feedback. Not only does it judge the system, but it's the best continuing education process we ever have had. And this was thought up through a pediatric emergency medicine physician at Children's of Alabama. We've done this since the very start of the trauma program. It is the best thing that we have ever done to complete that loop. So, having said that, why do we use secondary triage? Well, it helps us decide. Dr. Crawford covered this real well. It's very important for everybody in EMS to realize that each region sets its secondary triage criteria. It's not something the Department of Public Health, it's not something the ATCC fits. It is something that your region looks at and says, this patient in X minutes ought to go to Y hospital. That's what we follow at the Trauma Communications Center. Not something we set. It's not something, again, that ADPH sets. So, now, let's look at another patient to close us up and try to get us back. This was a call this spring. This was a call out of East Alabama. This was a 34-year-old male. He was crushed by a tree. It was midday. His airway was clear. His respirations were 16 a minute. He was 98% SpO2 on room air or outside air. Whoa, look at his C situation, though. 50/30, heart rate of 100. This individual had no radial pulses. They had to check the carotid to even tell that he had a pulse. He had no feeling from the waist down. He had lower extremity and pelvis. His pelvis was unstable. We talked about that as entry criteria. It was just a little bit less than 60 minutes to a level 1. So there was discussion between the communicator at TCC and the paramedics on the ambulance. Should we go to the closest level 3, level 2, and so forth? They were having trouble getting lines. We talked about putting on a pelvic sling. We got the pelvic sling on. We got a second line started. There wasn't any air transport available due to weather. So here's a kind of a time of 11:29, lifesaver paged out, initial response to the scene declines. 11:47, initial call from the scene, because they were smart. They asked for the air transport before they heard what they had. They asked for it before they even were on the scene. 11:52, a report to Regional Medical Center. We made the decision, paramedic made the decision, let's stop, let's do a pit stop. So they dropped in to RMC. RMC, the doctor came out, looked, said, hey, I'm glad you got the pelvic sling on. You got 2 lines. Y'all are doing what needs to be done. Go to Birmingham. So, again, we started the patient toward Birmingham. We checked availability of aircraft through TCC, which we will do, and see, can we get an aircraft to meet somewhere along the way? If we can do that, then we'll get the aircraft to rendezvous with the ground ambulance, and we'll expedite the transport in that situation. And then we had the paramedic called in to us and said the second line had blown and the pressure was down to 47 Powell. 1237, the trauma attending, we got the trauma attending on the line to see what she recommended at that point. They recommended that we stop at St. Vincent's East. However, the ambulance was moving quicker than we were moving, so they had already passed the exit, couldn't go to St. Vincent's East. St. Vincent's East was ready. They were ready to put blood to this patient because we can't put blood in pre-hospital care unless it's an aircraft. So 1248, they had passed the St. Vincent's East exit. 1254, we repaged the trauma back out, and 1323, the paramedic on the ambulance called us back and said, hey, we made it. He's still alive. He's in the trauma bay. The traumatologist and emergency medicine are taking care of him. So what happened with this patient, and did we make the right decisions? Well, I want you to look at all of the injuries that this patient had, and he had really, really significant injuries and probably should not have survived, especially with the degree of orthopedic injuries. And so this gives you an idea of why it is so important to consider that time element change. If we can maintain some level of systemic volume of blood in the patient to go to a level 1 where we can do surgery in multiple areas, not just the soft tissue injuries and not just the duodenal injuries like this patient had, but we can get that patient with multi-surgeons and multi-care going on, and that's what makes a level 1 hospital such a tremendous resource for all of us. And it's worth investing that extra 30 minutes of time or whatever to get that patient to the right hospital. And it means that that patient's, number 1, going to survive. Number 2, their hospitalization is going to be less. And number 3, they're going to return to a useful life. This patient was admitted on 4/11, as bad as he was. He was discharged to rehab on just a little over a month later. And look at that, fractured pelvis, all of those duodenal injuries, everything that he had. He was discharged home on 5/9 and leads a useful life as best he can today. I'm sure he's still going through rehab. This patient, as well as the first patient, would not be alive if it weren't for what EMS did, if it weren't for what the hospitals and the physicians did, and for what the trauma system did for these patients. That's just 2 success stories. Probably all of you have additional success stories. I will close with one conclusion for you. Those were really busy slides with the triage factors. We'd love for you to have them to be able to use them in your continuing education. If you use this whole video, it's great. If you don't want to use the whole video, if you'll talk to your region or to ADPH staff, we'll be glad to send you that PowerPoint, and we'll be glad to have you use it in your education, because I think it's important for all of us to know what that is. Thank you, Shauna.
Thank you,
I don't
Jim.
think I went over.
You did not. You did very good. And thank you for adding personal faces to why we do what we do for the state trauma health system. At this time, we're getting ready to go to a break, but before we go to break, we would like to remind everyone in the audience to make note of all your questions that you may have, because we will have question timing at the end of the program. We will take a short break, and we'll come back for our second portion of our program. Thank you. Welcome back. We're ready for our second portion of our presentation this morning. We have with us on our stadium Dr. Sarah Nafziger, and she's going to give an overview of our stroke system and our pending STEMI system. Dr. Sarah?
Thank you, Shauna. Thanks everyone for tuning in today. Now we're going to change gears a little bit and talk about stroke and our statewide stroke system. This is a project that we've been working on for the past couple of years very feverishly, and are happy to see it come to fruition now. Back in 2000, a stroke system was formed in the Birmingham area, modeled after the state trauma system. So a lot of what you hear us talk about today regarding stroke, we're going to say, yeah, this is very similar to trauma because we really modeled it after the success of the trauma system. This is a picture of the EMS regions in the state, and you may notice that this looks familiar because this map is very similar to our trauma system map. Only in this map we're mapping out our stroke centers in Alabama that are active currently. Pretty soon, as we're standing up our statewide stroke system, you'll see hospitals dotted all over this map as we bring up our statewide stroke system. Well, what are the goals of a statewide stroke system? Because if you're like me, when I completed my initial medical training, there wasn't a lot that we could do for stroke. But over the past few years, we've had some advances in technology and advances in the medical literature that have shown us that there is a treatment for stroke now. And primarily that's for ischemic strokes. We can give them a thrombolytic drug called TPA in a certain small subset of ischemic stroke patients who arrive to the hospital within a key period of time. And that's really the crux of our primary goal of the stroke system, is to get those patients who are eligible to receive that life-saving drug within the appropriate period of time. So it's very time dependent. Now, we also have a lot of other things that the stroke system does, and that really alludes to our secondary goal, which is to help, we are not only worried about the patients who can get TPA, but we're worried about all the other ischemic stroke patients and also our hemorrhagic stroke patients. So we want to help make sure we get those hospitals to the facilities that have the resources available to take care of them. So sometimes that's by getting the patient to that hospital immediately from EMS, and sometimes that's by facilitating a transfer. Now, there are some ground rules for our state stroke system, and these rules, many of them mirror our state trauma system. The first is that our system is voluntary for hospitals, and we certainly appreciate all the hospitals that participate in the system. But the system is mandatory for EMS, just like for the trauma system. So our EMS providers are mandated to participate in this system. The way we decide which patients go into the stroke system, we have really two different ways. The first is we talk about the FAST scale, also called the Cincinnati Stroke Scale. And that, if a patient has anything abnormal on that screening exam, then they automatically are entered into the stroke system. But as those of you who are healthcare providers know, if that's the only way we identify stroke patients, then we're going to miss a lot of stroke patients because there are a lot of stroke patients who have other symptoms. And so what we teach our EMS providers is that any other patient who has an acute neurologic finding or change that you can't explain with some other mechanism, those are patients that go in the stroke system, and we enter them under what we call EMS provider discretion. So kind of really the two ways of an abnormality on the FAST scale and any patient with an acute neurologic change that we can't otherwise explain. Those are the patients who go into the stroke system. Now, as you can imagine, a lot of patients who go into the stroke system ultimately end up having something else that was wrong with them. For example, it could be a patient who was elderly and had a UTI, and that's why they were having an acute neurologic finding. It could be something else entirely. It could have had a seizure. So there are a lot of different things, but right now those are the ways we enter the patients in the stroke system. And because of that, we do have some over triage with the stroke system, and we're going to go over some of those statistics later in the presentation. Just like trauma, patient choice can override the system and the routing as long as the patient is able to make a decision for themselves. Now, as you can imagine, sometimes it's hard to determine patient competency in the back of a moving ambulance. So we really do the best job that we can. We ask our EMS providers to really, make their best judgment call on the patient. But patients can override the system routing if the patient is able to decide for themselves. One key piece of this system is that the hospitals self-report their availability in real time, just like trauma. We don't tell a hospital when they are or are not available. They tell us, and that's the key that makes the system really work. Now, if all participating hospitals were available 24/7, then we wouldn't really need a system. We would just know which hospitals are stroke hospitals and which ones are not, and that's where we would take the patients. But because we all know the reality is that our hospital emergency departments have increasing volume, and hospitals are overrun with patients a lot of times. We have problems with boarding and a multitude of other problems. So hospitals, sometimes just are oversaturated, and so they may not be available We have equipment failures, things happen. And so because we live in the real world and we really do have those limited resources, we use the system so that the hospitals can let us know when they're available and when they're not. And that allows us to get those patients to the most appropriate facility. Now, just like trauma, this is a picture of the LifeTrack monitoring system where the hospitals report their availability in real time. This is a picture of an actual workstation. And this is a graphical representation that you may be able to look at a little more clearly. The print is a little bigger on it. And what you see on this workstation display is the hospitals are listed in the rows along the side. And the first three columns have availability listed for, it says T for trauma, S for stroke, and C is for cardiac. And we'll talk about that in a few minutes, the cardiac system or the STEMI system that Dr. Miller alluded to earlier. But T is for trauma, S is for stroke, and we had to pick C for cardiac since S was already used, so we couldn't use S for the STEMI system. The other columns represent different resources in the hospital. So you have your emergency department, anesthesia, operating room, different things like that. So each hospital can go in and list their availability for different things. I'm going to give you an example. Let's say you're at a hospital. Maybe it's a smaller hospital and you only have one CT machine or CAT scan machine. And let's say something happened and that machine is malfunctioned or unavailable. So that hospital, if that's a stroke hospital, they would then go into their workstation and turn themselves red for CT. And the logic built into the software would then turn that hospital red for stroke because, as you know, if you can't do a CT scan, then you can't properly evaluate a patient who may have a stroke. So that's just one example of how this software works. Now, this is a photo of an actual trauma system communicator in Birmingham at the Alabama Trauma Communication Center. And those of you who know anything about the Trauma Communication Center, or the TCC as we often call it, is their title says trauma, but they do a lot of other things. They do stroke, they do STEMI, they do disaster management. They're available to help in so many different areas. So it's not, their name is trauma because that's really how they started, but they do so many different things and provide a lot of services. But this is what it looks like in their communication center, and that's a communicator with his screens and monitoring statuses and talking on the phone and doing his job. Well, let's talk a little bit about stroke versus trauma because there's some similarities and differences in the two. Now, both of these illnesses are time-dependent. There's a time-dependent factor. In trauma, you have the golden hour when you're trying to get the patient somewhere to stop hemorrhage, usually. But in stroke, it's time-dependent also because you just have a very small subset of time, somewhere along 6 hours or less for ischemic strokes, to get those patients in, get them evaluated, and give that thrombolytic therapy that we were talking about. So both are time dependent, but there are some key differences. Most smaller hospitals do not have the resources to treat significant trauma. They can handle trauma patients, but not trauma system patients because that small subset of the most severely injured trauma patients they require a lot of resources, and we think of them as very resource intensive. Not only do they require a lot of machines, a lot of radiology, a lot of labs, but a lot of different physicians, a lot of nurses, and then ultimately a lot of rehab specialists. So trauma is very resource intensive. But on the flip side, stroke is less resource intensive. There's certain specific resources required, but even your smallest hospitals typically, if they desire to do so, can have those resources that you need to evaluate patients who may be having a stroke and begin that thrombolytic treatment that we talked about. So the nice thing about stroke is that even the smallest hospitals can participate in the stroke system if they want to make that commitment to the system. So let's talk a little bit about our data collection piece. As Dr. Crawford talked about with trauma, QA is a big part of our trauma system and is also a very important piece of our stroke system. We really try hard to make sure that we have a robust quality assurance system, and we do that by collecting data. While we have the desire to have a very robust quality assurance system, we also have a very small budget for the stroke system. And so we do this in a very simplistic manner that surprises a lot of people. We actually, when a patient is entered into the stroke system, there's actually a form that is faxed to the emergency department that receives the patient. And that paper form then gets filled out and returned back to the Trauma Communications Center by fax or email. And then the communicators then put that data into the stroke system, into the LifeTrack portion of stroke, and we track that data. So that's our data collection system for the stroke system. Now, just like trauma, our patients are identified by a unique system-generated number called the TCCID number. We don't use patient names in our system. We use those unique numbers. Predominantly, we don't know the patient's names most of the times when they get put in the system, so that's one of the big reasons why. And this is an example of what that patient report looks like. It has some basic parameters, including the TCC identification number, the receiving hospital, the EMS region, the EMS transporter, some basic information about the patient, like their vital signs, their Glasgow Coma Scale, things like that. And at the bottom, there's a rectangle that has 7 check boxes that are yes or no check boxes, and those are the data points that we collect for stroke. Now, right now we have 7 points. We have some plans to make that a little more robust in the future as we update our software, but right now that's our data collection and quality assurance system. All right, so we talked a little bit about which patients get entered into the stroke system already. I guess I got a little ahead of myself. But like we said, the patients with a positive FAST scale or any acute neurodeficit that you can't otherwise explain. And with that, we do get a lot of over-triage in the stroke system. A lot of patients who enter in the stroke system ultimately end up not having a stroke. In fact, it's a little more than half. We've decided that we're okay with that for a couple of reasons. One is that most of the stroke patients who get entered into the system, while more than half of them end up not having a stroke, they end up getting admitted to the hospital for another reason. Most of them are patients who require hospital admission. So you can really almost think of the stroke system as an acute neurologic emergency system. So that's kind of one big reason. And the other reason is that we have yet to find a scale that's more accurate, that's truly applicable in the EMS setting. There are some scales that are out there that are very complex. They take a long time to do, and we just really haven't found a better way to triage those patients that is applicable and something that we can do in the EMS setting now. So that's a couple of reasons for that. So what happens once the patient gets entered into the system? A conversation then happens between the EMS provider on the scene and the TCC communicator, and that patient is routed to the nearest appropriate stroke system hospital. So unlike trauma, most of the time these patients are always going to go to the closest stroke hospital rather than to a level 1, 2, or 3 depending on severity. Well, let's talk about patients that don't come in by EMS. How can those patients be entered in the system? Well, they certainly can be entered just like trauma as long as that patient is in the emergency department. The emergency department staff can enter that patient into the system, and certainly that happens sometimes. Sometimes EMS is just we're gonna blow it. We're gonna miss a stroke patient that we should have put in the system. Sometimes that patient's presentation may evolve and become more clear over time. Or sometimes, as we often know, the patients walk in the front door. They don't come by EMS. That may be a stroke system patient. So certainly the hospitals can enter patients into the stroke system. Even hospitals that are not participating in the stroke system or community hospitals, those hospitals can also enter the patient into the system and transfer that patient by simply calling the Alabama Trauma Communications Center. Well, our system is a 3-tier system, as I alluded to earlier, and it's very similar to trauma. At our top tier, we have our level 1s, or our comprehensive stroke centers. Level 2 are our primary stroke centers, and level 3 are our acute stroke-ready hospitals. And for those of you who know a little bit about the Joint Commission designation process for stroke centers, this nomenclature will be familiar to you because we modeled it just after the Joint Commission's certifications for stroke centers. And we basically took their criteria and mimicked that for our system. The reason for that is that hospitals who are designated by the Joint Commission at one of these levels we automatically accept those hospitals into our stroke system at that level. For level 2 and level 3 hospitals, if they do not have that designation, then we will actually go on site after they apply for designation at that level and do a site visit and go through that checklist of things just like Joint Commission does for the level 2 and level 3 hospitals to make sure that they do have those resources that they've represented that they have so that they can participate at that designated level. At this point in time, we do not provide through ADPH independent designation of comprehensive stroke centers. We do require Joint Commission designation as a comprehensive stroke center for a hospital to receive that level 1 designation. The reason for that is because it is a very complex designation and it really goes beyond our capabilities and resources at ADPH to confirm that designation status. So we do require Joint Commission comprehensive stroke center designation for our level 1 hospitals. At this point in time, we have one designated comprehensive stroke center within the state's borders, and I'll say kind of 1.5 external to the state, because we do have one in Tennessee that's already designated that will participate in our system, and one in Florida that is undergoing that process as well. So we do have some of those in our state system. We have several level 2s in our state system and a multitude of level 3s. Let's talk for just a second about the progress where we are in developing the state system. So we had the system operating in the Birmingham region since 2000. And when we went to model after that and make a model that could apply to the whole state, we developed our 3-tiered system. And we implemented that in the southeast region of the state. This is some regional data that compares how that pilot project went. You can see there's some key differences in the Birmingham area, also called BRIMS, and the southeast area of the state, mainly population density. In the Birmingham area, there are 217 persons per square mile as opposed to the southeast area, 80 per square mile. So you can see we're really comparing more of an urban area to more of a rural area, and they're both mixed, to be completely honest. So we pilot tested our new state stroke system in the southeast region and compared that data to what we've had in the Birmingham region that's been operational for 16 years now. And this is the data from that for our first few years piloting that. What we saw is we had similar number of patients in both regions and similar numbers of data compliance. And we saw that still we struggle with accuracy. What we see is a little over half the patients going in the stroke system actually ended up not having a stroke, and we talked about the reasons for that already. We see about a 22% hemorrhagic stroke rate that's similar in both regions, and with similar rates of ischemic strokes. But the most exciting thing on this slide that I would like you to look at that should really jump out at you is the TPA administration rates. And it's around 18% for both regions. That's phenomenal. The way we calculated that number is we take, for the numerator, is the number of patients who receive TPA, and the denominator is the total number of ischemic stroke patients. And that data is amazing because if you search the literature for what should that number be and what are other centers experiencing, that number is a lot higher than any of the reference data that you'll find in the literature. And that's the number we've been seeing consistently in our state stroke system, and we're very proud of that. For comparison, if you look at CMS data, that number's around 5%. So we're really pleased that we're pushing for people to go by those national guidelines and give TPA when it's appropriate. Kind of just as important, or maybe more important than that, is what we're not seeing with that. And what we're not seeing is a lot of adverse events. We're not seeing patients who receive TPA when they shouldn't have, or patients who receive TPA even when they should have, and having an intracranial hemorrhage from that. And so we're very pleased about that. We feel like we're making a big difference. And as you can see, somewhere around 80 to 84% of those patients are being admitted to the hospital. If they go in the system, they require admission. So our QA/QI process, as I mentioned, we use the data form that you saw. Many of our hospitals participate in Get With the Guidelines Stroke Registry, and the Alabama Department of Public Health has recently become a super user for Get With the Guidelines. So we're working on marrying that pre-hospital data to the hospital data so that we can have a much more robust QA/QI system. We do require for our state stroke system that 95% of those data forms get returned to us. So we do have some hospitals that have fallen short on that, and that's an area for improvement in our system. But you know, your data is only as good as the amount of information that you get back. So with incomplete data, we have incomplete knowledge. So hopefully we'll be able to achieve that number. The hospitals fax that report back to the Alabama Trauma Communication Center within 48 hours, and that information gets entered into the LifeTrack system as we talked about. So let's talk a little bit about where we are in the development of the state stroke system. I told you we already have that system functioning in the BRIMS region and in the Southeast region, but currently we've been working on standing up the system statewide. So statewide, we've received applications from multiple hospitals stating their intention and desire to participate in the state stroke system. We've completed site visits by our site visit team at most of those hospitals now, actually. It's been a very busy few months, but very pleasant because we got to go around and visit people all over the state in different hospitals and meet them and see what they're doing for stroke. So we've almost completed all of the hospital site visits. So as soon as we complete all those, then we'll hopefully be able to progress and stand up our state stroke system this fall as we complete our education in each region and our designation process. As you can imagine, there's a lot of cost associated with that. The stroke system uses the TCC, or the Centralized Communication Center, that we already talked about. We do have increased call volume there, so it does require an extra communicator, which is a cost. There's the cost of the computer workstations in each hospital. Most of the hospitals that participate already have one there that we're utilizing for trauma, so that's not an additional cost for us. We have to pay for the time of the ADPH staff, the regional EMS staff, the site visits and travel for those site visits. So there are some costs associated with stroke, but we've been able to minimize that by piggybacking onto the trauma system. Some things that are important to note is there's no funding for hospitals to participate in this system. It's strictly voluntary. That's something that we would hope we would have in the future, but right now there's simply not money to pay hospitals to participate. We don't have money to create a specific stroke registry like Get With the Guidelines. We would love to be able to do that, but right now we do not have the funding. Many hospitals already participate in that, so we're grateful for that, but we do not have the funding to pay for them to participate. So I'll close out by talking about the challenges. One thing that we looked at as we set this system up is the really explosion and expansion of telemedicine as opposed to the old traditional telephone consults. We've received overwhelmingly positive feedback from hospitals that have implemented telemedicine, both from the emergency department staff who have initiated consults and from the neurologists who are performing the consults on the other end. We hope that telemedicine is going to continue to grow in our state as there's limited availability of neurologists, but we don't see it as commonly as we would like to right now. There are financial limitations to that, as you can imagine, so we're seeing that expand more and more, and we hope to continue to see that expansion. We do have a challenge in that some emergency department physicians are still a little resistant or reluctant to administering TPA. Let's face it, it's a very scary proposition when you're giving somebody a drug that could cause hemorrhage if you don't select patients appropriately. We do see strengthening in the national guidelines about when that drug should be given, and our experience with that drug has we've become more and more comfortable with it, and we're very comfortable with the current guidelines. But some physicians are still a little slow to embrace that, so that's an educational barrier that we've had to overcome. I say on this slide that we need to keep our neurosurgeons happy by not abusing them. You know, neurosurgeons are also a type of physician that is in short supply, and we want to make sure that we don't overburden our neurosurgeons at any one particular facility by overburdening them with these intracranial hemorrhage patients who sometimes need their services. So we try very hard to make sure that we take care of them so that we're not overburdening them and overutilizing a specific resource. And then, of course, our current challenge is just to roll the system statewide. We've spent a multitude of hours on it recently with that implementation, and we're very close to that goal of being able to turn the system on statewide. So hopefully within the coming months, by the fall, you'll be able to see that implemented in your area. Well, thank you very much for your attention, and I'm now going to turn it back to Shauna.
Thank you, Dr. Sarah, for a very detailed explanation of our stroke system and for our pending STEMI system. We realize that there's a lot of information that's been shared with everyone this morning. We would like to remind you all that we will have questions at the end of the program, so please jot those questions down. In addition, this program will be available for review at a later time on the Alabama Department of Public Health website. So don't feel like you have to maintain or retain all the information you're hearing at the moment. You will have an opportunity or more opportunities to receive this information as you need it. Okay, at this point in the program, we need to turn our attention to our essential partners in our regions. We want you to hear from our regional directors, as has been stated earlier. Our system is comprised of 6 EMS regions, and we want you to hear from those people in those regions who are our eyes and our ears to make sure this system functions the way that it needs to function in order to save lives in the state of Alabama. We're going to start our program, this portion, with our Region 1 representative. Dion?
Thank you, Shauna. Good morning. My name is Dion Schultz. I'm the Alabama EMS Region 1 Coordinator, also known as AERO. AERO serves as the liaison office to the Alabama EMS. Currently, we are participating in the Alabama trauma system, and soon we will be bringing the stroke system online in our region. AERO provides education to the EMSPs in our region. We do this by direct training, train-the-trainer, and online education. AERO provides ATS changes and updates quarterly through our MDAC meetings to our regional agencies. And we are also want to let everybody know that we are available by phone or by email for any questions or assistance that our EMSPs or agencies have, and they can call us at any time. As Dr. Crawford mentioned earlier about the feedback forms that the hospitals give us, those feedback forms come to our office, and then we take those forms and we distribute them to the transporting agency that provided the direct care for that patient. Those forms are distributed to the assigned training manager or trauma manager for that agency. We get those forms from the hospitals, and within 7 days those forms are back to those agencies. If any EMSP would have questions regarding a ATS patient that they put into the system and have not received a form or have not received any information from their trainer, please feel free to contact us and we will help you with that communication. We also want to talk about the communications that we have with our hospitals. Each one of our hospitals that are participating in our system, we do communicate. We do that by phone calls, emails, and we visit them on a regular basis. The discussions that we have with our hospitals are the documentation, improved suggestions, and then system concerns. We also communicate with our hospitals through our statewide conference call that is scheduled through the Alabama EMS region office. I also want to talk about the concerns that we have within the region. Those concerns go through a QI process, which is either started at the regional office or started at the TCC. Those concerns are reviewed by the AERO office, and then if deemed necessary, we pass those on to the agencies or hospitals in question for them to look at and to resolve at their end. If a resolution cannot be taken care of at the regional office, those concerns then are passed up to the Alabama Office of EMS. Thank you very much.
Thank you, Dion, and we cannot do it without you. Region 2, John.
Yes, thank you very much. My name is John Blue, and I serve as Director for Region 2, which is the eastern portion of Alabama. In addition to, and I'll just elaborate just a little bit on the things specific, we certainly, each of the regions are unique, but also follow the standards, as Dion pointed out, in serving our trauma system and our health system. Region 2, like others, are designated by the Alabama Department of Public Health to serve as a regional lead agency. It is a physician-led program under the medical direction of Dr. Neil Christian and 6 associate medical directors serving 4 zones or 4 areas. We provide administrative support and educational resources to our healthcare population. That population is made up of 13 hospitals, over 100 pre-hospital providers. Trauma, we have 1 level 2, 7 level 3 facilities, 5 community hospitals. 6 of our 13 hospitals have completed the site visits and are awaiting final designation. Several of those facilities had previous certifications in stroke. Current statistics that we're operating and being reported to both our MDAC, our Medical Direction and Accountability Committee, as well as our RTAC, some 7,500 patients have been entered into the trauma system, and even though we're awaiting designation, we've already entered over 500 patients in the stroke system in East Alabama. We have an extreme commitment to continuous quality improvement. Our region has, in addition to the memorandum of understanding between the hospitals, our 13 facilities, and the Alabama Department of Public Health, those hospital CEOs and chief medical officers at each of those 13 hospitals signed a commitment memorandum of understanding with our office that they will, on a monthly or bi-monthly basis, have ongoing meetings between the physician ER groups, our offline medical directors, and our online physicians to meet with the hospital administration, the chief medical officer, with our services, to look at prospective and retrospectively the charts of all patients coming in, not only trauma, not only stroke and STEMI, to make sure that every patient counts. And we are, of course, supporting a system that saves lives. Unique to our region, we're working with the Coldwater Mountain Bike Trails, the Alabama's highest point of mountain for hiking, our major waterways, Talladega Superspeedway, the Federal Emergency Management Agency, which houses the Center for Domestic Preparedness and Noble Training Facilities, which will be celebrating over 1 million students have been trained at that facility in East Alabama, reaching out to America's first responders throughout the United States and abroad. Be happy to take any questions upon conclusion. It's a pleasure to work with the department.
Thank you, John Blue. Joe? We get to hear from Joe a second time as representative from his region.
You know, every region's different, and so every region report to you is going to be a little bit different. We come from a 7-county region. You've seen a lot of the data. The staff at BRIMS is 3 paramedics, 1 part-time medical director, and 2 support staff. The 2 support staff really run the program, and everybody in BRIMS knows that. And so they come and see Tanya, and they come and see Aubrey. They don't come to see Joe or John or Michael. Education is the key to change in all of these programs. And our regions are founded in the educational concept that this is how we make changes in patient outcomes, not through a regulatory process, but through an educational process, and that's why data is so important. I want to thank all of the EMS providers, the hospital administrators who have supported us over the years, financially and with their direction to the people who work within the hospitals, the physicians, the emergency medicine physicians, the traumatologists, the neurologists, and the cardiologists who make up the system. They drive us. They tell us what they want. We want the system to work for them. Now, I've got 4 points I want to make very quickly. 1, call us from the scene. You wouldn't go to a 911 call if you didn't know where you were going. So how can you leave a scene if you don't really know where you're going? Call us at ATCC from the scene. Give us a report. If you think A, B, C, D, E, then report A, B, C, D, E. You're going to do better patient care. You're going to give us a quicker report. We're going to take up less of your time if you'll give us a good, solid report. Airways patent, breathing, respiratory rate, 16 a minute, SpO2 of 98%, pressure is less than 90 systolic. We need to go to a level 1. You know, that's the way we need a report. And so we don't care if it was Uncle Frank or Aunt Minnie. That's not our issue. We need that patient information right then. If you're going to use an aircraft and you make that decision, call us en route. Let us know you want an aircraft. Let us know you've scrambled an aircraft. Don't rely on the aircraft to make the contact with us at TCC after they leave the scene. Saturday morning, early Sunday morning, 7-minute notification on an aircraft coming in to UAB. We have the same problem with USA, same problem with Huntsville Hospital. Give us that call. Don't rely on the aircraft. They got a lot to do in that aircraft. They got a lot to do clearing with all the FAA stuff. Give us the information. And, you know, the last thing, hospitals are constantly changing. They change on a minute-to-minute basis. They change on a daily basis. They change their focus from month to month. Sometimes in EMS, we don't know that until after the fact. This is a chance for us to know that. This is a tool for you to use as a pre-hospital provider, as an in-hospital provider, to enhance the level of patient care you can get to your hospital.
Thank you.
I am Glenn Davis, the West Region Director, Region 4. It's a pleasure to be here on this outstanding group of presenters. Our region is primarily rural. We have one urban area that's Tuscaloosa. We only have 0 level 1s. We have 1 level 2 that happens to be in Mississippi and 2 level 3. So we hit our knees every day thanking REMS and UAB for taking care of our trauma patients, and if it wasn't for them, we would be really hurting at this time. But we're extremely grateful for that. We're also, though, thankful for the level 2s that we do have that does step up to the plate and take care of our secondary triage, and we're very thankful for DCH that has a very outstanding record for putting outcome reports to the ATCC, in turn gets those reports back out to the providers. So although we're a very rural service, we're represented by some outstanding physicians under the director of Dr. Crawford, who keeps a continuous finger on the pulse of the physician and the patient care that's going on. And we look forward to continue hearing about the evaluations and the outcome studies that's going on, and trying to improve, like this conference is all about. We have a mission to reduce mortality and morbidity throughout the state. Trauma system, stroke system, and the STEMI that's coming out is going to do that. And we're grateful for our region to have an opportunity to work hand in hand with my fellow regions in the state to make that happen.
Lufang, the Director of the Southeast Alabama EMS region, which is Region 5. Dr. Fred Pick is our Regional Medical Director, and our office is in Dothan. Our region is comprised of 18 counties, which is 1/4 of the land area of the state, but we are mostly rural. We are the other region that is in the stroke system. We've been very excited to be in that system for 2 years. We have 18 stroke system hospitals, 5 are level 2s and 13 are level 3s. We also have 13 trauma system hospitals, 2 level 2s and 11 level 3s, and we have over 70 EMS providers in our 18 county area. 55 of them transport patients and 20 are non-transport services. I'd like to thank all of them, the hospitals and the pre-hospital services, for their support of this system. It has been wonderful, and we really appreciate all y'all do to help us do this. We also have St. Francis in Columbus, Georgia, that has joined the Alabama Trauma System, which borders up to us there in the Phoenix City and Russell County area. And that has been a lifesaver for us because that area is very rural. Russell County is one of the counties in Alabama that does not have a hospital except for the Jack Houston Orthopedic Hospital. Midtown in Columbus has also applied to join the stroke system, and we should have them up and running very soon. Again, thanks Shauna and the State EMS office for all of your support.
Good morning. I'm David Garman, and I'm the Director of Alabama Region 6, which is the Alabama Gulf region. One of the unique aspects of our particular region is that there's only 66 miles between Mississippi and Florida along our coastline there. So in addition to treating all of the local citizens that we have, we entertain a little over 6 million tourists on an annual basis. We've been a part of the trauma system now since 2009. With this, we utilize all of our hospitals within our region, plus we use 2 that are over in the Pensacola area. And now we have one of the hospitals over in Mississippi who is coming on board for actually all 3 levels for that. So from the trauma side, we have 2 level 1 hospitals, which is USA Medical Center in Mobile and Sacred Heart Hospital over in Pensacola. We also have 1 level 1, which is the Baptist Hospital in Pensacola. We have 10 level 3s, and in the very rural areas of our region, we actually have 3 hospitals that are community-based with that. So the system seems to be working extremely well within our region, as well as the other regions, as the data shows. But our daily responsibilities for all 6 of our regions, from the standpoint of working with the acute care systems, has been mainly to, once a situation has been brought to our attention, we review it, we investigate it, we do the appropriate education as we see that we need to do. We also follow up and track because, as Joe said, data is just invaluable. We have got to have the data to know what we're doing and what improvements we need to certainly be making. We also make timely and appropriate reports, of course, with the Office of EMS to accomplish this. I'd also like to take a moment to thank all of the EMS personnel for everything that you do. I know oftentimes you may feel that you don't get thanked for your job, but you are a valuable asset and a valuable part of the healthcare system. Certainly would also like to thank all healthcare providers because this is the only way the system is going to work. So just thank you for everything that you do.
Thank you, David. Thank you, David. As you can tell from our audience, we've been talking about acute system of care that is multi-tiered. But it takes all of us that are in this audience and other people that are not really in this audience to make it work. It takes all of the people who are listening to this program to make it work. No job is small. All of us have key roles to ensure that the citizens of Alabama, whether they're critically injured or whether they have come to a situation where they have been stricken with a stroke or a cardiac condition, it takes all of us doing the best that we can to ensure their survivability and to improve their lifestyle post the incident. At this point in our program, we want to open up the lines and we want to take your questions because we want to make sure that you understand exactly why we're doing what we're doing. We want to make sure that when this program is ended, that you feel very secure about your role and your position and what you're doing to make sure that we're saving the lives of the citizens in Alabama. Do we have any questions? Do we have any questions in our audience?
Yes.
Yes, David.
Could Joe explain the difference between TSO and TBO and compare that to, of course, the medical diversions that sometimes we see? But those terminologies, TSO and TBO, seem to present some conflicts. People don't really understand what we're talking about.
Okay. So do you understand the question?
Trauma system overload and traumatic brain overload were both created because we need to protect the resources of our level ones. And what we found early on was that the resources of our level ones that get taxed the most are the initial intake point in that hospital, which is the emergency department. It's the second part of that service line resource that gets taxed very heavily is the trauma surgeon or the neurologist if it's a stroke. And then the third thing that gets taxed is the bed availability to accept a patient that has needed either surgery and trauma or needs to be evaluated and maintained or cared for with a trauma critical care trained physician or an acute stroke neurologist once they go to a stroke ICU bed. So what we found was that can we intervene and take those patients for trauma and turn around, and when we begin to get tight on one of those service line resources, whether it's the emergency department and the number of patients in the trauma bay in a level 1, and these are all level 1 criteria only. They're not level 2, level 3. Well, they are level 2, I'm sorry. And so that we're impeded volume-wise in the ED. We're impeded volume-wise because the trauma surgeons are all operating right then, or we're impeded or likely to be impeded with no bed availability, and we get tight in any of those areas. Then it's up to the trauma attending for trauma system overload to call us at ATCC. Only that trauma attending is the one who can tell us that X hospital is on trauma system overload. It's that trauma attending that is the key decision maker within that facility, not anybody else. We work for them at that situation. When TSO occurs, we look at trauma system entries. If they're coming in under non-physiologic status situations, a physiologic status on trauma system overload, go straight to the level 1 as they would normally do. However, if we're on TSO, they come in under MOI, Anatomic, EMT discretion, then we're going to look. Normally they would have gone to the level 1, but we're going to say, hey, look, we're on TSO, we're about to wipe our resources out. Can you help us? Let's go to a level 2. Normally it would have been a 1. Let's go to a level 3 if normally it would have been a level 1 or a level 2. So it's to protect that bed availability so we don't go red. The worst thing that happens to us in the trauma system is go red with a level 1, because that means we not only, as Dr. Brevard said, we don't have enough level 1s, but we don't have enough level 1s if we lose them out of the system because they're overloaded. So we want to protect those beds. Second area, traumatic brain overload. And that doesn't, none of this looks at medical divert patients, only trauma system patients. Traumatic brain overload. We don't have enough neurosurgeons. Not only do we not have neurosurgeons for stroke, we don't have enough for trauma. Neurosurgeons willing to take care of those patients. So a level 1 hospital can go on traumatic brain overload. And we want to keep the hospital open as much as we can also. So those patients with isolated head injuries, when that level 1 trauma hospital is on traumatic brain overload, then we will reroute them elsewhere. And normally, at least within BREMS, and as we get the stroke system, an added benefit of the stroke system is that we look at a stroke-ready hospital who has a neurosurgeon, a CAT scan, stroke ICU bed, and say, wow, we got a level 3 trauma hospital. They're green. We got them green as a stroke hospital. We got those resources that are tight and are non-existent in the level 1 hospital. We can still keep them open for every patient except isolated head injury patients, and we can send those traumatic brain injury patients to a level 3 stroke hospital because they can do the initial care and evaluation in the emergency department. They can get the patient upstairs. They've got the CAT scan. They got the neurologist or neurosurgeon, and they got the stroke ICU bed. Again, I would reemphasize, this doesn't affect anything except trauma system patients. If you know a hospital is on traumatic brain overload, take them to non-trauma system patients. That doesn't hurt anything. But it hurts us terribly if we don't get those patients routed the first time. David, did that answer?
Yes. Thank you.
Very good. Thank you. Do we have any closing comments from our panel? Okay.
Thank you to ADPH. You know, most state agencies don't turn around and look at what they've done and ask, especially those of us involved in it, are we doing a good job? What do you understand? What do you not understand? When ADPH made the decision to send out the questionnaires, sent them out, spent considerable staff time, they took that data, and they not only got the data, but they used the data, and that's why we're here this morning. So this is a plan to improve everything for all of us. And I really thank ADPH EMS personnel for their leadership in this area and for making sure we continue to do our job.
And we thank you, Joe. And as Joe stated in closing, we really wanted to just make sure we give you all an opportunity to hear from us exactly why we're doing what we're doing. And in closing, we want to remind you, for all of the participants who would like to receive continuing education credits, all nurses and paramedics, you have to fill out the sign-in log and send it in to the to the mailing address that's listed on the sign-in log. For all physicians who would like to receive CME credits, you have to send in your original sign-in log and your evaluation. Sign-in log and evaluations, original forms for the physician CMEs. And in closing, we thank you for participating.